Okay. Sorry for the back and forth, up and down, in and out. And indeed, I do want to welcome you all again on behalf of Rick, who is really the instigator of this amazing conference that has grown this year to 1,900 participants. It's really been an immensely rewarding experience, and I thank Rick for allowing me to give some of these introductory lectures looking to the future, and I hope that I can engage your interest. I do have several potential conflicts related to this specific talk. What I want for Hanukkah and Christmas. That's going to be the title of my talk. I only have 3 wishes for gifts this year, besides the well-being for all of our patients. The first is for a cost-effective therapeutic drug monitoring for biologics. My second wish is the ability to dose adjust biologics to optimize treatment for our patients. And my third wish is for a reliable surrogate for mucosal healing. And let's see if I can get a tune out of this. Maybe you guys. I want it, I want it, I want it, I want it, I want it. Who was that? If anyone gets it. Okay, to begin with, I want an assay that is cost and effective in allowing us to adjust doses for patients on biologic therapies. I would urge you to look at the recent article that Bill Sanborn, Brian Fagan, and his colleagues wrote in Clinical Gastroenterology and Hepatology just in the past several months, really for a wonderful overview of this topic. And I want to breeze through some specific issues regarding this and related to this important topic. We've become accustomed to drug monitoring in the field of internal medicine and in gastroenterology. And indeed, for many years, we've done drug monitoring, for instance, for cyclosporin in our field to optimize drugs. For azathioprine and the thiopurines, we've learned how to optimize therapy either according to weight-based or metabolite monitoring. Biologic agents are not significantly different aside from the route of administration. They have a pharmacokinetics that is going to depend upon the route of administration, the dose, and then of course the individual parameters for the specific agents. Each is going to have a different pharmacokinetic and hence pharmacodynamic property. And what's replicated on this slide are potential dosing schedules for either the intravenous formulation of infliximab or the subcutaneous formulation of adalimumab. And let's start with a very simple concept. Let's assume that there is a therapeutic level above which the drug maintains its efficacy and below which, when levels drop below this therapeutic threshold, which may be different for individual drugs, and we're seeking those, or different assays, when levels fall below that, several things are actually happening. The effect of absent blood levels includes recurrence of the disease activity. We know that when you mop up TNF, and we've seen this both clinically, endoscopically, and histologically, we get mucosal healing. When levels fall below that threshold, the disease is going to recur. Or, if the drug is ineffective, there will be no primary response. But a second thing happens to biologic agents, these foreign proteins, when levels fall below detectable limits. And that is, our bodies develop antibodies against these, known as immunogenicity. And as most of the audience is aware, this accounts for a significant number of patients, by no means all, but a significant number of situations where patients lose response after gaining response to the agent. Now, in Ortis and colleagues' paper, they've identified a number of factors that may impact upon the pharmacokinetics of monoclonal antibodies. These include the presence of anti-drug antibodies due to the immunogenicity, which decrease serum levels of these and increase the clearance. The concomitant use of immunosuppressives, as we have seen in all of the trials with the different biologics, as well as the recent SONIC and COMMIT studies, also reduce the immunogenicity of these agents. And we've seen this for several decades now with the use of methotrexate in rheumatoid arthritis. Individuals who have a high baseline levels of TNF, particularly in the mucosa, may see this as, the body may see this as a mop for anti-drug antibodies and rapidly induce clearance. And there are several other factors that may or may not be as intuitive, including the presence of low albumin or high C-reactive protein that are associated with more rapid clearance. And then a few other factors such as body size and male gender are associated with a more rapid clearance and hence an impact on the pharmacokinetics of these biologic agents. Just several examples, and there are many, and we've discussing this throughout this conference, on the impact of levels of biologics on the outcomes of disease. The Toronto group was one of the first to recognize that trough serum infliximab levels might impact on a number of variables, including clinical remissions, endoscopic remissions, C-reactive protein, and complete endoscopic resolution. Similarly, and I'm going to show examples for both infliximab, adalimumab, and it applies to certolizumab and any eventual mAb that comes into our therapeutic armamentarium. But similarly, although we may not have a distinct threshold level yet for adalimumab, it's clear that patients who maintain higher levels can sustain clinical remissions and responses longer than patients who drop below a threshold level. Those are both examples in Crohn's disease, and we see similar examples from the Toronto group in ulcerative colitis pertaining to clinical endoscopic remission and the risk for colectomy associated with the presence or absence of blood levels in ulcerative colitis, and recent analyses of the ACT 1 and 2 trial with infliximab in ulcerative colitis, looking at quartile analyses of trough blood levels. In the patients who have the lowest group of blood levels, the early responses were 26%, compared to the patients who had the highest levels of 43%. And even more impressively, after a year of treatment, only 21% of patients in the lowest quartile of blood levels were in a clinical remission, compared to 60%. Look at how we can increase the response of patients by monitoring their levels and by obtaining optimization of these drugs. Now, thus far, we have, I think, pretty good guidance on what we should do for patients who are losing response. The guidance is not so clear at the present moment as far as prospective monitoring, but we are assimilating continuous data regarding that. Again, the Bill Sanborn and the Mayo Group have developed some therapeutic algorithms that have actually been tested. In individuals who are losing response to therapy and have positive anti-monoclonal antibodies who've developed immunogenicity, those are individuals who would more likely benefit from a change to another anti-TNF, because increasing the monoclonal antibody dose of the same drug is eventually going to lead to futility. If there's then no response with the change, then we would move to a second mechanism. However, in patients who are losing response and have subtherapeutic concentrations of the monoclonal antibody, whichever it would be, those are individuals who are essentially out of gas, and we need to fill up their tank by either increasing the dose or decreasing the frequency of administration. It is possible to change to a different mechanism of action, but it's not necessary if we're only dealing with an empty gas tank. And then if there's no response to increasing the dose, that's when the mechanism is no longer going to be effective, and it's not going to be useful to switch to a similar anti-TNF mechanism. If there's no response, then we would again change. Now, what about patients who do have presence of antibody in their serum but are losing response? Well, we would emphasize that these are patients who need a clinical reevaluation before making any additional maneuvers. If indeed their endoscopy, C-reactive protein, imaging studies show active disease, continuing or shifting, either continuing or increasing the dose of the same agent or shifting to another anti-TNF agent is unlikely to give us a response. In this situation, if there is active disease, it would make much more sense, it's much more logical to investigate for alternative symptoms in the absence of inflammation, but switching to a different mechanism if the patients do have active inflammation. And indeed, the Mayo group tested this hypothesis looking retrospectively at groups of patients. In their individuals who were positive for human anti-chimeric antibodies and had lost response to infliximab, as you can see, switching to an alternative anti-TNF had a much better prognosis for individuals than increasing the dose of the same drug to try and overcome the antibodies. In contrast, in patients who had subtherapeutic levels of infliximab but were losing response, nearly the same proportion, 90% of patients, improved by just increasing the dose. So we do have now, I believe, a rational approach of how to monitor patients for loss of response. What we need is a cost-effective assay that we can use in our clinical practice for this. Now, as I mentioned, we're pretty good now, and there's a good consensus of what to do for patients who are losing response. The next issue is how are we going to prospectively maintain levels? And there is preliminary data from a number of series that demonstrate that if we maintain trough levels along the way, we are more likely to maintain response with any of our monoclonal antibodies. Now, my second wish for Hanukkah is the ability to dose adjust. We can do this as physicians, but the impediment in this situation is actually third-party payers. It's become a major hassle for those of us who want to increase doses according to either blood levels or loss of response for our patients. And indeed, we have evidence in bits and pieces regarding that potential to increase dose and recapture response. So from a single referral center that was published last year or presented last year at Digestive Disease Week, looking at dose intensification for individuals who required it, and this was up to 40% in this one center. At the University of Chicago, our experience with infliximab, adalimumab, or certolizumab pegol is approximately 50%. Maybe we're dealing with more refractory patients, but about 50% of our patients are requiring dose adjustment, and often that's early on within the first year. And this is in the setting of Crohn's disease. We're learning even more with ulcerative colitis that the likely need for dose incremental adjustment is probably even greater, particularly in the severe ulcerative colitis in the hospitalized setting. In the CHARM study, looking at adalimumab in Crohn's disease, with the ability to increase the dose from 40 milligrams of adalimumab every other week to 40 milligrams weekly, nearly a quarter of the patients, or over a quarter of the patients in the clinical trial, required dose adjustment, and approximately half of the patients who were losing response in the trial were able to recapture their response with dose incremental increases. And this makes sense because we know that there is an influence of both immunogenicity with infliximab, adalimumab, and certolizumab pegol as well. And we can see that the proportion of patients in this center looking at a sustained clinical response gradually reduced over time. On the other hand, when they increased the dosage of adalimumab, they were able to recapture the response for their patients. And this makes sense because what happened was when we looked at trough levels with increasing the dose, a significant proportion of patients were able to re-achieve response with dose escalation. And this has been seen in several other centers. This is data, again, demonstrating the need for dose adjustments with any agent, be it infliximab or adalimumab from this center, and the median time for that need is within the first 6 months of therapy. So I think we need to consider the potential for flexibility, and we need additional data on this so we can convince our third-party payers regarding this. And my final request for my Christmas present is another cost-effective biomarker for mucosal healing. These have obviously been topics for these symposia over the past year and focusing on this year. And Corey Siegel gave a wonderful discussion at our morning satellite regarding biomarkers related to mucosal healing. The Mayo Group has looked at the impact of fecal markers, both calprotectin and lactoferrin, as a correlate to not only clinical indices, being the Crohn's Disease Activity Index, but also endoscopy. So we've seen in retrospective analyses and some prospective series that these fecal markers do correlate, at least with endoscopic scoring systems. The question is whether they actually are sensitive and specific enough to document the fact that there is mucosal healing. Fecal calprotectin as a marker of disease activity has been looked at in both ulcerative colitis and Crohn's disease, but not as a primary endpoint in clinical trials. They've been put as composite indices, but they do correlate with remissions as well as deep remissions, but they also correlate with flare-ups, such that in patients in a deep remission, both clinical and endoscopic, calprotectin's less than a level of 50 correlated with the deep remission, and patients who had elevations in their calprotectin predicted flare-ups. Fecal lactoferrin is another alternative. It has not been studied as much as calprotectin in inflammatory bowel disease, but there is data regarding fecal lactoferrin, which does associate it with both flare-ups with higher levels and remissions. There's less reliability with mucosal activity with lactoferrin, but also does correlate with histology. And Jim Lewis has analyzed in a composite review the operating characteristics of lactoferrin and calprotectin regarding their sensitivity and specificity. And you can see as far as disease activity, there is a good, but not yet perfect, correlation. We need some studies looking at prospective endpoints of calprotectin. And again, in both Crohn's and ulcerative colitis, you can see that individuals who have low levels of calprotectin have a better long-term course compared to patients who have calprotectin that's present continuously in the feces. As far as a predictor of relapse, calprotectin, again, is able to predict in several series, but calprotectin is operating characteristics are going to depend on both the location of the disease and the type of disease activity. So we need to clarify this better within the future. Relapse rates can also be predicted, as I've already mentioned. And in a study from Europe, and I have to congratulate Arne Roseth, who always attends these meetings and is really one of the inventors of calprotectin. When I met Arne a number of years ago, his intent was to develop a bedside test that cost $5 to predict disease activity. Currently, calprotectin is a send-out laboratory, at least in our center, and costs about $250, and we do not get an immediate result. The lab test has to go out. But when used at the bedside, can be used to detect subsequent inflammation as well as predicting flare-ups. So It's Christmas time, it's Hanukkah time. You can't always get what you want, but
you can't always get what you want. You can't always get what you want. You can't always get what you want. But if you try sometimes, well, you might find you get what you need.
Santa was here already, and I hope we are getting what we need. Thank you.